of anatomy of the heart, gross anatomy of the heart. And firstly, we'll just take a quick look at the pericardium. We don't have to spend a lot of time talking about the pericardium because we talked about the pleura when we did the lungs, and the pericardium and the pleura develop in fundamentally the same way. The cavities are from the coelom. It's really the same story that we talked about there. There's one important difference between pericardium and pleura. For pleura, we talked about there being two layers, a visceral layer and a parietal layer. The visceral layer being on the lung and the parietal layer being outside of that on the other side of the cavity. Well, in the heart, we have those same two layers. We have a visceral layer of pericardium that's on the surface of the heart, and then we have a parietal layer outside of that with a cavity, pericardial cavity in between. But in addition to that, there's a third layer called the fibrous pericardium. So the fibrous pericardium and the parietal pericardium are fused together into structurally a single layer. The important point about this is that the fibrous pericardium is fibrous. It's a very tough, strong, collagenous layer. And the important point is it's not elastic. It doesn't stretch. So the importance of that is that it means that if you have a rapid accumulation of fluid in the pericardial cavity, such as, for example, bleeding into the pericardial cavity, because the fibrous pericardium will not stretch, the pericardial cavity cannot expand outward to accommodate that increased fluid volume. And if it can't expand outward, it's going to expand inward. And that inward expansion of the cavity to accommodate that increased volume, that inward expansion is going to be compressing the heart. And that compression of the heart is going to interfere with venous filling and therefore interfere with diastolic filling of the ventricles. So that means that end diastolic volume will be decreased, which means stroke volume would be decreased, cardiac output would be decreased, blood pressure is decreased. This is called cardiac tamponade. Cardiac tamponade, the compression of the heart, resulting in those physiological endpoints because of the increased fluid volume in the pericardial cavity. And that compression of the heart is occurring because the fibrous pericardium is preventing the cavity from expanding outward. So because that is a life-threatening situation, the fluid in the pericardial cavity has to be removed through pericardiocentesis in order to relieve the pressure on the heart and allow it to expand normally and have diastolic filling return to normal. Okay, so that's all we'll say about the pericardium. Let's now turn our attention to the internal anatomy of the heart a little bit. So let's first look inside the atrium. So if we look inside the atrium, we'll see that the atrium, as we already talked about, has a rough-walled part and a smooth-walled part. Remember, those have two different embryonic origins. The rough-walled part is from the primitive atrium. The smooth-walled part is from the sinus venosus. There is a distinct ridge that separates those two parts. It's called the crista terminalis. That ridge would correspond to the embryonic junction between the sinus venosus and the primitive atrium. In the adult, that smooth-walled part, because it is derived from the sinus venosus, in the adult is called the sinus venarum. The sinus venarum. It's what used to be the sinus venosus. And since all of the venous return to the heart came into that sinus venosus, we now see that all of the venous return to the heart is entering the sinus venarum. So all of the veins that come into the heart, the superior vena cava, the inferior vena cava, and the coronary sinus, all three of them enter the right atrium in the smooth-walled part or the sinus venarum. The rough-walled part, the trabeculated part, has these ridges of muscle. Those ridges of muscles are given names. They're called pectinate muscles. So the pectinate muscles are the ridges of muscle that make the rough wall rough. They're called pectinate muscles. Okay? All right, we've already talked about the fossa ovalis that we see on the septum, and we've mentioned the entry point of the coronary sinus, the IVC and the SVC, and here we see the tricuspid valve exiting from the right atrium. If we look into the ventricles of the heart, again we will see rough-walled parts and smooth-walled parts. Again, remember the rough-walled parts come from the primitive ventricle, the smooth-walled parts come from the bulbus cordis that get incorporated into the ventricle. The ridges of muscle in the ventricle that make the rough wall rough are called trabeculae carni. That's fundamentally the same thing as what we call pectinate muscles in the atrium. They're just given a different name in the ventricle. In the ventricle, they're called trabeculae carni. But also, very important, extending from the ventricular wall into the interior chamber of the ventricle, we have these projections of cardiac muscle that extend from the ventricular wall into the chamber, and they are called papillary muscles. Papillary muscles. So the trabeculae carni are just going from ventricular wall to ventricular wall, okay? But the papillary muscles go from ventricular wall into the chamber of the ventricle and end in the chamber. At the tips of those papillary muscles, there are fibrous bands or fibrous cords or tendon-like structures, and they're called chordae tendineae. And those chordae tendineae attach the papillary muscle to the edges of the cusps on the two sides, the tricuspid and mitral valves. Mitral valve on the left, tricuspid valve on the right. But it's the same thing on both sides. You have chordae tendineae attaching papillary muscles to the free edges of those cusps. So what's the function? Why do we have papillary muscles and chordae tendineae? So let me firstly dispel a misconception. You know, if you look at this and you say, well, you've got these muscles here that look like they would pull down on the valve, and if you pull down on the valve, that would be opening the valve. So maybe these muscles act to open those valves. That's not true at all. That's completely false. Because remember, those valves open during filling of the left ventricle, in other words, during diastole. Well, these muscles are really extensions of the ventricular wall, so they wouldn't be contracting during diastole. So that doesn't make sense. Since they are extensions of the ventricular wall, they are contracting during systole. And systole is when these valves have to close to prevent backflow. So what are they doing? Well, what they are doing is, what's causing the valve to close is the pressure gradient between the ventricle and the atrium. As the ventricles start to contract, it increases the pressure in the ventricle, making ventricular pressure higher than atrial pressure, pushing the valves up. What the papillary muscles and chordae tendineae are doing, they are limiting how far up those valves can move, because as those valves get pushed up, they will initially close the AV canal, but if they keep moving up, they will invert basically, or prolapse as the word is called, as it's called, prolapse, and turn inside out and basically become incompetent. In other words, allowing blood to flow back into the atrium. So the papillary muscles and chordae tendineae are not opening the valves. What they're in fact doing is controlling closure of the valves. So they're contracting during systole to prevent closure, to restrict closure, to limit how far the valve can go so that they only go far enough to cause closure of the AV canal, but not so far as to result in prolapse and therefore an incompetent valve. So understanding that explains why, if you have ruptures of the chordae tendineae, as sometimes can occur with perhaps endocarditis, ruptures of the chordae tendineae can lead to prolapse of the valve. Or similarly, if you were to have a myocardial infarct that involved one or more papillary muscles, well, that in fact infarcted papillary muscle would result in inability to limit the closure of that valve, and again would lead to prolapse with regurgitation through that valve. Okay, so that's what the function of the papillary muscles and chordae tendineae is. Okay, so let's Now move on and take a look at the blood supply to the heart. The heart is supplied usually by two arteries, two coronary arteries, a right and a left coronary artery. There's the right coronary artery, there's the left coronary artery. Those two arteries are direct branches of the ascending aorta. They are the only branches of the ascending aorta. The right coronary artery emerges from the right side of the ascending aorta, and it immediately enters the coronary sulcus. And it stays in the coronary sulcus. Remember, the coronary sulcus is called coronary because it goes around the heart like a crown, so the right coronary artery stays in that sulcus and goes around the heart in the coronary sulcus. Now remember that the coronary sulcus is also called the atrioventricular sulcus because it's separating atrium from ventricle. So that means that this right coronary artery is sitting right between the right atrium and right ventricle, which therefore suggests that what it supplies is the right atrium and right ventricle, which is true. And so you can sort of generalize that and say that for all of the coronary arteries, all of the vessels, as long as you know where the vessel is, you'll know what it supplies, because these vessels simply supply their surrounding neighborhood. So if this is in the boundary between right atrium and right ventricle, it supplies right atrium and right ventricle. Now, as the right coronary continues around the back of the heart in the coronary sulcus rather, it gives off a branch that goes down into the interventricular sulcus, called the posterior interventricular artery. Sometimes you'll hear it called the posterior descending artery, same thing. But posterior interventricular tells you that it's sitting between the ventricles on the posterior side. And so that tells you that it's going to supply the two ventricles, right and left ventricle, as well as the posterior part of the ventricular septum. Okay, so that is a branch of the right coronary. The left coronary comes off from the left side of the ascending aorta. And in contrast to the right coronary is a fairly long artery. The left coronary is a pretty short artery. It's only about an inch long. It extends to the left just far enough to get past the pulmonary trunk. And once it gets past the pulmonary trunk, it ends by dividing into two branches. One branch is called the circumflex branch of the left coronary, or the circumflex artery. Okay, the circumflex artery. And the circumflex enters the coronary sulcus on the left side. So again, coronary sulcus means it's between atrium and ventricle, so the circumflex artery is supplying the left atrium and left ventricle. And it stays in the coronary sulcus around the back of the heart. And remember, we already have the right coronary artery in that coronary sulcus. Now we have the circumflex artery in the coronary sulcus. So those two arteries are sort of coming at each other from opposite directions. So we see the possibility for collateral channels, anastomotic connections between the circumflex branch of the left coronary and the right coronary. And so that is an important collateral pathway, because that would mean that if you were to have perhaps a partial occlusion of the right coronary artery, the tissue normally supplied by the right coronary could therefore be supplied by the left coronary by way of the circumflex, and its anastomosis with the right coronary, and vice versa. The other branch of the left coronary artery, this one is called the anterior interventricular artery, or more frequently called the left anterior descending, or LAD. But again, if you remember, it's interventricular. That means it's sitting between the two ventricles, so it supplies both ventricles on the front wall of the heart, as well as the anterior portion of the ventricular septum. This artery stays in the interventricular sulcus, goes around to the posterior side, still in the interventricular sulcus. Remember, we already have an artery in that interventricular sulcus called the posterior interventricular. And so now we see that those two arteries are coming at each other end to end. So again, since one is a branch of the left coronary, the other is a branch of the right coronary, again, we have the opportunity for collateral channels, for anastomotic connections between the left coronary and right coronary circulations. Same story as before. Okay? So those are the major blood vessels that you should know about. If the heart has arteries, it must also have veins, which it does. It's not important to know the details of the venous drainage and where each of the cardiac veins are. They're called cardiac veins, not coronary veins, cardiac veins. But the major point that I want you to take from this is that almost all, not all, but almost all of the veins of the heart, almost all the cardiac veins drain into one large vein, seen here on the back of the heart, sitting in the sulcus between left atrium and left ventricle. In other words, sitting in the coronary sulcus is this large vein, and it's called the coronary sinus. So you have lots of individual cardiac veins draining into the coronary sinus, and then the coronary sinus drains directly into the right atrium. So there is that third major inflow into the right atrium. In addition to the inferior vena cava and the superior vena cava, we also have the coronary sinus, bringing back most, not all, most of the venous drainage from the heart itself back to the right atrium.